Dear colleagues, welcome to this session. We'll immediately start this session. This is the first time the APSPOS, Asia Pacific Paediatric Ophthalmology and Strabismus Society, which is a society representing Asia Pacific, I would say. It is a great honor, the first time APSPOS joining the Sri Lanka meeting. I'm deeply thankful to Amala for the very kind invitation and a lot of hard work efforts put in to making us joining together. And I'm deeply honored. I'm representing APSPOS. I'm the Secretary General of the APSPOS, Jason Yan from Hong Kong. Today, we have a meeting composing various topics. Here with me is Professor Saurabh Jain, Professor of the UCL Medical School, and we are chairing this session. And I will pass the mic to Professor Saurabh Jain to start the symposium.
Good afternoon, and thank you so much for inviting us. It's a real pleasure to be back in beautiful Sri Lanka and to have a Pediatric Ophthalmology Day. So what we're going to try, and it's great to start early. I mean, that's the first for me, so that's fantastic. So we're going to start with Frank Martin, who is a professor at the University of Sydney, and he's going to talk to us when do we need to perform imaging in sudden onset strabismus and pediatric nystagmus. So this is going to be the only virtual talk of the session. So over to Professor Martin.
Thank you, Sir Brian and Jason. My topic is when do we need to perform neuroimaging for sudden onset strabismus in children and in pediatric nystagmus. Let's look at two quotations. Science, my lad, is made up of mistakes, though mistakes which it is useful to make because they lead to the truth. And from Theory Henry, you learn from your mistakes. Well, on this topic, I can honestly say I have learned from my mistakes. Let's look at my first case, Harry, a 4-year-old referred to me for a second opinion. He developed left esotropia at the age of 6 months. He attended an ophthalmologist, found to be hyperopic with astigmatism. A diagnosis of accommodative esotropia was made. He was prescribed glasses, which have been worn full term. Part-time right occlusion of 2 hours a day was commenced, and despite occlusion, his left vision has not improved. His parents, in his history, said quite clearly that he's clumsy and unsteady on his feet. I examined Harry, found vision of his 6 on 7.5 and 6 on 36. He had a part accommodative left esotropia with poor left fixation. Eye movements were normal. I checked his refraction, no different to what was found by his ophthalmologist, and in retinal examination found the optic disc and retina of both eyes to be healthy. I advised his parents that I agree with other ophthalmologists' diagnosis and management. I recommended continuing with glasses. I increased right occlusion to 4 hours a day. I arranged to review Harry in 3 months. And I indicated to his parents that if his left vision had not improved, I would arrange for investigations. 1 month later, I received a telephone call from Harry's dad. Harry has been admitted urgently to hospital. He has bilateral papilledema. He's had an MRI. He has a glioma. So what were my mistakes? First of all, I ignored that despite good compliance with part-time right occlusion, there was no improvement in left visual acuity. And secondly, I ignored the history that he is clumsy and unsteady on his feet. So when do we image a child who has sudden onset strabismus? We image the child if from the history there are any neurological symptoms, headache, vertigo, diplopia, nausea and vomiting, reduced coordination. And from our examination, if our clinical examination does not explain the reason for the strabismus. Like with Harry, we thought hyperopia explained it, but it didn't. If the child has neurological signs, cranial nerve neuropathy, pupillary signs, associated nystagmus, optic nerve problem, papilledema or atrophy, or if the child does not fit a clinical pattern. Harry's vision did not improve with patching. Let's look at my second case, Natalia. Natalia was referred to me at the age of 4 months by a paediatrician. Natalia had very poor eye contact. Parents doubted if she could see. Nystagmus had developed around the age of 6 to 8 weeks. Development was normal. There was no family history of nystagmus of any other ocular problem. I examined Natalia. I noted that she was a very fair child. She had poor visual responses. I thought perhaps she looked at light. Horizontal jerk nystagmus. I could perform an adequate slit lamp examination to look for transillumination. Refraction was age-appropriate hyperopia. I considered the optic discs to be normal, and I noted that she had blonde fundi. I made a provisional diagnosis of possibly oculocutaneous albinism, or could it be congenital idiopathic nystagmus? I questioned it, and I didn't really make a definite diagnosis. I arranged for review in 4 weeks. 4 weeks later, Natalia returned. Her vision was still extremely poor, and there was no change in nystagmus. As I was examining her, I noted she had a bulging anterior fontanelle. I looked at her fundi, and she had pale, swollen optic discs. I arranged urgent neuroimaging, and Natalia had a large optic glioma involving both optic nerves and chiasm. I reflected as to what mistakes I had made. Well, first of all, from the history, I overlooked poor vision and didn't really focus on it. She had unexplained nystagmus. So these were the two things that I should have focused on more when I saw Natalia, and I should have organised her MRI at the initial consultation. So when I consider nystagmus in the paediatric age group, I divided into infantile nystagmus syndrome, which we used to call congenital nystagmus, but it's not truly congenital, as the nystagmus typically comes on between 6 weeks and 4 months of age. And then we've got acquired nystagmus, which can come on at any age. What's the etiology of infantile nystagmus syndrome? It can be due to ocular pathology causing various degrees of visual impairment. It can be very obvious, bilateral dense cataracts, optic nerve hyperplasia, retinal dysplasia, or it can be subtle, a retinal dystrophy, or something further back along the optic nerve. There can be neurological abnormalities with or without ocular pathology. Then we've got the so-called isolated inherited or idiopathic ocular motor disorder. This was what we refer to as congenital idiopathic nystagmus. And then there are other causes which should be obvious, like albinism, can be vestibular, which is nystagmus often worse in the dark than light, syndromes like Joubert's, Downs, systemic disorders, disorders of glycosylation. And then we have the special types of nystagmus. These often are acquired. We have seesaw nystagmus. This is a localizing sign of something in the rostral midbrain. We have convergence retraction nystagmus, a localizing sign of something in the dorsal midbrain. It can be opsoclonus, which is not a true nystagmus, but can signify a neuroblastoma. It can be vertical, downbeat nystagmus in Arnold Chiari or sedated with sedatives, monocular, then dissociated nystagmus. Diffusional maldeveloped nystagmus syndrome, late nystagmus syndrome, is a benign condition. And then there's vestibular nystagmus. So when I see a child with nystagmus, how do I assess this child? I ascertain, does the child have good vision at near or not? If there's good vision at near, it's almost certainly going to be congenital idiopathic nystagmus. This is a diagnosis of exclusion. A child with poor nystagmus, there'll be some pathology somewhere from the front of the eye to the chiasm. Or acquired nystagmus? This child must have some form of pathology. The history and clinical examination will allow you to make a diagnosis in 90% of patients. So when do we perform neuroimaging in pediatric nystagmus? If the etiology of nystagmus is not detected at clinical examination or with ancillary testing, image all children with acquired nystagmus and image all children with special types of nystagmus except for those with latent nystagmus. So what have I learned? Listen carefully to what the parent tells you. Do not ignore any suspicious symptom or sign, and have a low threshold for neuroimaging a child about who you have any concern. Thank you. I'd like to invite all of you to attend and participate in the 3rd Congress of APSPOS next June in Brisbane. Come and enjoy the sunny weather. Thank you.
So Dr. Martin will be joining us online, so you'll get a chance to question him directly. So we'll move on to our next speaker, who is Dr. Yan, who is a clinical assistant professor from the Singapore National Eye Centre. We're going to talk about the pre-myopia management, a new paradigm.
Okay. Good afternoon, everyone, and thank you for the kind introduction. It's a pleasure to be here. So today I'll be speaking on pre-myopia as well as is it a successful paradigm shift in terms of preventive therapy. So in general, the issue that we are facing right now is that myopia is an increasing trend, and as we know, 50% by 2050 will be myopic and 10% will be highly myopic. So these figures have been re-emphasized multiple times already, but what is the main issue is that all these patients, in the end, they are still myopic. And as we later will know, as patients get more and more myopic, the higher the risk there is. So now there's another thought, whether we can even prevent them from reaching the myopic stage. And that's why now there's more thought being put in to suggest that whether pre-myopia is actually a viable choice. So, as Prof. Mark Bullimore has published in his landmark paper, that every diopter counts. With every diopter build-up, it results in either, depending on the denominator, it results in either a 30 to 60% increase or decrease in the risk of developing sight-threatening complications such as myopic macular degeneration or things like retinal detachment or like cracks. And hence, it might not be just sufficient to slow down myopia per se, but actually try to prevent the onset in the totality. Right, and so what are the options right now that have been investigated? So first one would be lifestyle choice, which is more outdoor activities, 2 hours per day under the light. But other interventions include things like atropine eye drops as well as low-level red light repeated therapy. And so the first one was actually published by Prof. Yam back in 2023. So this is the most important one so far to date, where he looked at the use of the low concentration atropine, whether it was successful in preventing the onset of myopia through the LEM2 study. And so from there, the results, we can see that there's actually significant protection or a retardation in terms of the myopia development. And as you can see, compared to placebo and atropine 0.01, is the atropine that 0.05 that shows a significant reduction, about 50% compared to the control rate. So with a control at 53%, what we get is actually reduction to 28.4. So in general, it means that about 1 in 4 children will still develop or progress to myopia compared to about 1 in 2. So generally, we are saving about 1 out of 4 children for everyone that we treat. And this is so for a population age group of 4 to 9 years old over a course of 2 years. All right, and so that was significant. And the next one is that preventing a fast myopic shift is a rather stringent guideline over here. That was the definition, which was 1 diopter over 2 years, which it equates to at least 0.5 diopters per year. So that's a bit more stringent, but in that sense, it still prevents about half of them, actually it saves half of the children from being fast myopia into a slow myopia progressor or even non-progressor. And again, compared to atropine 0.01 and the placebo, the 0.05 is the superior the product. And this again is translated for axial length elongation, where from 0.7 it is reduced to 0.48 millimeters. And in that sense, if we divide by 2, it's about 0.24 millimeters per year. And for the age group of 4 to 9, that's a pretty acceptable rate of elongation, especially with normative data coming out from places like Taiwan and China, that we know that 0.24 mm in this age group is pretty acceptable. Right, and so that is also significant. So earlier on, in a slightly different context, Prof. Wu Wei-Chang from Taiwan also looked at this pre-myopia management, and this was about a decade plus ago, where he used atropine 0.025. So as we know so far, the 0.01 doesn't seem to have significant impact on the protection against pre-myopia. So looking at 0.025, it is another alternative that's available. So as we can see, again, it's about half reduction or so from 54% of a placebo to 21% over a 1-year incidence. Right? And these are for patients of the pre-myopia range defined between minus 0.5 to plus 0.5. And same thing we see for the fast myopic shift, that it can drastically reduce from 58% to 8%. And similarly for spherical equivalent, we can see that it's a reduction of a minus 0.14 diopters versus a minus 0.58 diopters. So quite a significant reduction against the placebo cohort, though knowing that this is only a small retrospective cohort as compared to the LAM2 study, which was a larger prospective trial over 2 years. And the last one that has been just been published last year is by Prof. Herming Kwang, which looked at the effect of repeated low-level red light therapy for myopia prevention, and that's amongst children in China with pre-myopia. And because of it was conducted during the COVID period, so it was split into 2 groups. One that is totally without COVID interruption, where they could come back for repeated follow-up, and the second group, which is a totality of the all group of average for all those under treatment, where some had interruption and some did not have interruption compared to the control group. And again, we can see that with treatment, with the low-level red light therapy, it actually reduced the progression or preventing myopia development significantly from about 61% to 40.8 or 28.1%, depending on which group we are comparing. But even in the so-called a combined interrupted / non-interrupted group, it was still a saving of about 40% as compared to the control group, right? And this was across a 1-year period. So that was preventing the onset. In terms of axial length elongation, again, we can see a significant reduction from 0.47 to 0.24, which is quite similar to what the atropine 0.05 showed of a 0.24 millimeters per year elongation, which is within acceptable norm for this age group. And hence, it shows that there is significant reduction, and this was coupled with a slight increase in choroidal thickness. As you can see, 70% of the groups, they had some interruption, but even there, overall, there was a 3.0 nanometer thickness increase as compared to the control group, where there was a minus 9.2 decrease in the choroidal thickness. And this was again shown if spherical equivalent changes, and it matches what is observed with the axial length elongation. So again, it's a significant reduction, either within about 50% to 70+% to 80% sort of a reduction range compared to those who are under the control group. So it then has shown that it seems that both atropine 0.05, 0.025, as well as low-level repeated red light therapy can have significant effects in terms of retardation or prevention of developing myopia. However, special mention for the low-level red light therapy is that they've noticed that those who are between 0 to plus 0.5 tend to do better as compared to those who are the treatment group, where they are already between -0 to -0.5. So if you look at the left side, the relative efficacy, that means prevention, is about 64% versus those who are between 0 to minus 0.5, which is only 14%. And that is again seen both for spherical equivalent changes as well as the axial length changes. So again, much more significant, it's important to prevent them from even getting below 0 at this stage, right? And of course, with red light therapy, there are of course some concerns due to the strength of the illumination. So 2 actually withdrew from the study because of after images, and whether the other intensities or duration of treatment is required or whether there's any long-term side effects, those are still unknown at this point. Right. So what else? So in general, now that we know that, okay, it seems to be pretty effective, then there are certain things that comes to mind with this set of results. So firstly, most of the children, they are investigated in the age range of between 4 to 9. So what about those above? And after 2 years, which is the longest study so far, is this effect, what happens after this? Is this effect sustained or will they have any acceleration, right? And again, all 3 studies are mainly conducted in the Chinese population. What about the rest of the non-Chinese Asian population? Will we see a similar trend or protective result as well? In terms of forms, so far we have is 0.05, 0.025, and shown that 0.01 doesn't work. What about other availabilities like 0.125 or even 1% atropine? As well as the newer modalities like Deems Holt, if we were to give a plano form, because right now they don't really have the hyperopic form, if we give the plano form, does it really help? Of course, then next comes the reliability of the products, reliability of the results. Can it be reproduced? And what is the real world benefit? Is there significant side effects? Are parents willing to entertain? And so translating into clinical practice right now, what we know is that we have the results now, all right? Someone has thought about it, there's the result, and then now we need to convince clinicians to adopt this new form. However, how do we get parents to actually come in with their children? So there needs to be a patient journey at this stage. So it needs to go through a few things like increasing awareness, school triaging, such that, and then informing parents so that they can then bring their child in for further assessment, right? And so at this point in time, my last few slides, these are possible scenarios that can be thought of where a child can actually benefit from such pre-myopia treatment. So one where one side is slightly hyperopic and the other eye is already myopic. One where there's significant family history, such as siblings as well as parents having significant myopia, or those where they are significantly progressing at a faster rate even though they are not at the myopic range yet, from their hyperopic reserve is gradually significantly decreasing. And though the last option where someone just suddenly steps into a room with their highly hyperacute, hyper-aware parents, however, that is still currently under a very rare occurrence so far. So to end off with a case study, so this is a particular patient that's seen in clinic, 5-year-old child with a 0.25 and a 0.5 hyperopia, cycloplegic refraction. Elder sister is already having, is a 9-year-old already on atropine, and very anxious parents with moderate myopia. And they're working, usually leaving the child to be with the grandparents, and usually grandparents will indulge them with near electronic gadgets. So we can see that there is a high myopia risk profile in this, and current risk of myopia sequelae, not really, because he's still in the hyperopic range, right? He's a pre-myope. So what are the options, and where is there significant risk? All those are still in their favor. However, after this special discussion with the parents and long-term long consultation, overall parents still decide to go for careful monitoring. So to summarize, pre-myopia management is now a new thought form. Is it a paradigm shift yet? Maybe not, but it takes time for clinicians to buy into the results, for more results to come out, and then subsequently, then maybe we can then convince parents whether this form of a treatment would be effective for their children. Thank you very much.
Thank you very much. Do we have any questions? Okay, if you think of any, we'll get the panelists back. Thank you very much. That's a fantastic lecture.
So we have our next speaker, Dr. Jeremy Hu, consultant ophthalmologist, National Healthcare Group Eye Institute, Tan Tock Seng Hospital from Singapore. He will share on the low-dose atropine in myopia management.
So today, my topic for today will be low-dose atropine and myopia management, and how I apply evidence-based medicine to my practice. So for the purpose of today's discussion, we have a young child who is diagnosed with myopia, and the mother is keen to start on atropine eye drops. So as a practicing ophthalmologist, intending to start atropine for myopia management, here are some questions that one may ask. At what age should I start patients on atropine? What concentration should I start with? What should I do if myopia progresses while on atropine? And when should I stop? So I shall share with you how I use evidence-based medicine to guide my practice. To start, myopia is characterized by excessive axial elongation due to increased vitreous chamber depth of the eyes, causing light to focus in front of the retina, and historically thought to be due to excessive accommodation leading to myopia. Hence, atropine was used as it paralyzes accommodation. And trials done decades ago showed it performed better than placebo. However, it was found in animal studies subsequently that there are actually non-accommodative mechanisms at play. Hence, the exact mechanism of how atropine works is still unknown, but we know it modulates biological mechanism, mainly in the retina and sclera. So there's a paradigm shift following the publication of ATOM2 study, in which 400 children were randomized into different concentrations of atropine. Originally, it was intended by the authors to have minimal placebo-like effect by diluting 1% atropine 100 times, and it was intended to be sort of a placebo in that study. But the atropine 0.01 turned out to have a good efficacy on myopia control while maintaining minimal side effects. Hence, that kick-started the use of low-dose atropine in myopia control. Hence, when we first intended to start the patient on atropine, what are the considerations we should take into account? What age can we start them on, and who should have it? So looking at previous randomized controlled trials, most are generally done in the school-going age, usually hovering at the lowest about 5 years old, except for the LAMP study, who recruited 2 4-year-old patients. And with the LAMP study, they looked at the effect of age on treatment responses to atropine, and found that the younger the patient, the more likely they are to progress and they require a higher concentration to achieve a similar reduction as compared to older kids. So in my decision tree to determine whether to start a patient on atropine, I'll first determine if they have risk factors for myopia, such as age of onset, parental myopia, as well as if they have progression more than minus 0.5 diopter per year. And then subsequently, if I decided to start a patient on atropine, the next question I'll ask is what concentration should I start them off with? And to answer this, we need to figure out whether there is indeed a dose-related response to atropine for myopia control. So looking at the 2 randomized controlled trials in the ATOM2 study, if we were to look at the third column there, the ATOM2 study, the different concentrations perform rather similarly in terms of the progression, myopia progression over 2 years, whereas in the LAMP study, there is a dose-related response. So in face of these 2 contrasting results, we looked into a network meta-analysis to try to answer this. And to start off, atropine at any concentration performs better than no treatment at all. So that's atropine definitely works. But then at what concentration, if we look across the different concentration and look at the overall myopia progression, it seems that the dose-related response is less clear. If you looked at the last column there, the 0.05 seems to perform almost equivalent to the 1% atropine. But the side effect profile follows more of a dose-related response, in which is a stepwise progression in the pupil diameter as well as the accommodative amplitude. So the authors conclude that the 1%, the 0.5%, and the 0.05% atropine were the most efficacious in myopia management. So the recommendations by the AAO in 2017 recommended starting off with atropine 0.01, but the recent updated WISPOS myopia consensus statement in 2023 stopped short of giving a specific concentration to start off with, but instead summarized the different efficacy of atropine concentration. They also note that there's about 10% non-responders despite high-dose atropine. So then, that leads us to the next question. Suppose that the patient we started on 0.01, and what should I do if they still continue to progress? So most randomized controlled trials look at treatment-naive patients and put them on over different concentrations of atropine to determine their response. However, I'm not too sure whether it's the same response you get with patients who are already treated on lower dose atropine. Does higher dose atropine actually perform similarly in this cohort of patients? So when we look at the ATOM and the LAMP study, we can see about 20% of patients who are on 0.01% still progress over more than 2 diopters over 2 years. So without any good RCTs to answer this, we looked at our own unpublished internal audit results on children who were switched from 0.01% to 0.05% due to myopia progression. So in our center, we carry these 2 particular doses, and patients who progressed while being on 0.01 was switched to 0.05% if they progressed. The definition of progression is left to the treating physician, but here it's the overall real-life experience. The mean age of atropine 0.01% in our cohort of 123 patients were around 8 years old, and they were switched to around 10 years old at 0.05%. So subsequently, there's an increase of around minus 1.5 diopters over 2 years in which they were on the separate 2 eye drops before they were switched. And the mean cervical equivalent change while on atropine 0.01% was about minus 0.9 diopters, and while they are on minus 0.05, or they were on 0.05% atropine, they progress only a minus 0.3. Of course, this is not a robust RCT, and there are inherent confounders within it, but this gives a real-life perspective of our own experience. So then, with that, comes the next question that we will try to answer. When do we stop atropine? So first, we need to determine what happens when we stop atropine. So in the ATOM studies, they show that the higher the concentration of atropine the patients were on, that there's a higher risk of rebound. So if we look at the first graph over there at the top left-hand corner, where the atropine was 1%, okay, here. So this graph shows the 1% atropine. It has the best efficacy in controlling initially, but when they will abruptly stop here, there's the highest risk of rebound as well. So this follows a stepwise, it is also a concentration-dependent response. So the higher the concentration of rebound happens when you stop atropine with a higher concentration abruptly. So this is similarly replicated in the LAMP studies, although the effect was less and it's less significant in the LAMP studies, but also they do see a rebound effect when atropine was stopped suddenly. So with the ATOM2 study, we were to look at the washout phase where the patients was stopped atropine abruptly for a year, and then they were retreated if they were have a progression of minus 0.5 diopter in 1 year with an atropine of 0.01%. So if you were to look at the graph here, if they were stopped at less than 8 years old, nearly 62% of them requires retreatment. Whereas if you were to stop them much later in the teens, then it drops down quite drastically to 8%. So with that, my decision tree on whether to stop the patient on atropine is based on the following key considerations. Firstly, it will be the age of the child. Usually I tend to stop them when they are in the teens and when their myopia progression has stabilizes, and if they are on a higher dose of atropine, I will tend to taper rather than to stop abruptly. With that, thank you.
Thank you. Do you have any questions for Jeremy? Dr. Hu? Okay, can I ask you a question, if that's okay?
Sure.
So, do you measure the axial length in these children, and if so, how does that feed into your protocol?
Yes, we do measure their axial length. So we tend to look at them in terms of when I should decide to stop atropine. So once their axial length has stabilizes, not increasing more than 0.2 per year, and then I tend to start to think of stopping them. Yeah.
Thank you very much.
Thank you.
Okay, so I'd like to welcome Dr. Lilian Fu, who's a consultant ophthalmologist at the SNEC in Singapore, to talk about some real-life clinical cases in childhood myopia management.
Thank you, Dr. Jen, for the very kind introduction. Thank you, everyone, for taking your time to join us in this segment of the symposium. I also like to take this opportunity to thank the organizing committee, Dr. Sonel and Prof. Yang, for the kind invitation to be here. Today, I'll be presenting on clinical cases in childhood myopia management. I'll start off with a clinical case. It's a 5-year-old Chinese, parents with high myopia and not wearing glasses at this point in time, 5-year-old child. So parents are keen to delay the onset of myopia, and this is so because we know that the earlier the onset of myopia, the higher the risk of high myopia later on in life. And so this child presented with a visual acuity of 6.6 in both eyes, and on cycloplegic refraction, we found that he is low myope of plus 0.25 on the right and plus 0.5 on the left-hand side. Otherwise, the rest of the examination is unremarkable. So the million-dollar question here is, how would you manage this child at this point in time? Will you A, go for monitoring, B, advise for more outdoors time, C, provide single vision glasses, or D, start atropine eye drops? So in this case, I managed by advising more outdoor time, and I'm going to share with you why so, based on the evidence-based approach. So based on this IMI paper, Prevention of Myopia and its Progression, what it has been reported was that every 2 hours spent every day reduced the odds of developing myopia. And also, the odds reduction for every additional hour per week is 2%. And outdoors time has also been shown to reduce the axial length progression risk. So we move on with the same case, but now 2 years later, the child is 7 years old and they are working parents, so they are unable to fulfill the outdoor requirements. Difficult to take the child outdoor to spend at least 2 hours a day. At this point in time, when we examine the child, he has developed low myopia, minus 0.5 on the right, minus 0.75 on the left. So during cycloplegic refraction in clinic, we also found that the child has anxiety towards putting in eye drops. So parents also learn about a specific myopia control spectacle lenses. So we move back to the million-dollar question. How would you manage this child at this point in time? Low myopia in both eyes. Will you give single vision glasses, bifocal glasses, progressive glasses, or none of the above? So in this child, we shouldn't give any of the above from A to C. And why so? Because currently, as technology advances, innovations, there are myopia control spectacle lenses that can slow down myopia progression. And this includes the defocus incorporated multiple segments glasses by Hoya. There's also a highly aspherical lenslet technology that was published subsequently by Essilor-Stellus. Also, there's cylindrical annular refractive element spectacle lens by Zeiss, also known as the CARE lens. And up next, there will be diffusion optic technology that utilizes the decrease in contrast sensitivity. As you can see, once the lens is over the eye, there is decrease in contrast sensitivity, and this has been shown to also help slow down the rate of progression, as opposed to the earlier three, which works by peripheral defocus technology. So this child, another 2 years later, now he should be about 9 years old. Yes, he is now the school basketball team captain. He would like to consider contact lenses because sports, difficult to wear glasses when they play sports activities. So on examination of this child, he is currently -1 diopter on the right side and -1.5 diopters in the left eye. The rest of the ocular examination is otherwise unremarkable other than some slight increase in axial length progression. Again now, this child is 9 years old and would like to consider contact lenses. Would you give single vision soft contact lens? B. Prescribe rigid gas permeable RGP lenses for the child. C. Autokeratology lenses. Or D. Dual focus contact lenses. So in this case, you can manage by either auto-K or dual focus contact lens. And why so? Same thing, we go by an evidence-based approach. So there are soft contact lenses now in the market that can help to slow down the rate of myopia progression, and these are daily disposable lenses, can even treat up to -10 diopters of myopia, and even with astigmatism. I mean, personally, clinically, I even can treat up to close to 2 diopters of seal without having any significant blurring of vision, despite it being a non-toric soft contact lens. It's advisable to wear about 5 to 6 days a week, about 8 to 10 hours a day. Auto-K has been long-standing, has also been shown to help to slow down the rate of myopia progression. Usually advise the child to wear at least 8 hours to sleep. So now the child is 11 years old, taking major examinations, would like to counter the excessive near work because examinations-wise, they tend to read more, leading to progression. He's now about -2 in the right eye and -2.5 in the left eye. So 11 years old child taking exams have a lot of near work reading. What would you do? Wearing contact lens, remember he's a basketball school captain. Will you add low dose atropines to the contact lens? Add moderate dose atropine? Add high dose atropine? Or add blue light therapy? So in this patient, I managed by adding low-dose atropine eye drops. And what are the evidence, you may ask, with regards to combination treatment? There are currently a mixture of evidence in the literature that supports as well as the proof of combination therapy. So we start with 2019. It's a 2-year study, auto-K with atropine. And this study shows, a tick on the left-hand side, which shows evidence in supporting the combination therapy of auto-K with 0.01% atropine. How about in the year 2020? There's another trial, same thing, low-dose atropine with auto-K. And these studies also support the use of combination therapy, shown by a tick in the left-hand side as well. How about 2022? So now is comparing 0.01 atropine with progressive lenses as well as defocus soft contact lens. However, this Adenas study shows that there's no difference marked by a cross, adding 0.01 to either progressive or defocus soft lens. So moving ahead, 2022, we have another study, poor responder to auto-K. Is there a use of adding 0.01%? Oh well, doesn't seem so. So it's a cross. Probably they are also poor responder. They also fast development and progression in terms of axial length. And 2022, she did a study comparing auto-K with 0.01%. And it's a tick. So there is significant improvement in terms of slowing down the rate of progression. Adenas 2022 did another study. Defocus soft contact lens this time round, not auto-K. So what he found that there's no significant difference adding 0.01 to defocus soft contact lens. Palo 2023, he did a study on DIMS, which is the MyoSmart, with 0.01. it does shows that there is significant difference in terms of slowing down progression. And finally, 2024, Eddie Nurse again, he did another study, multifocal with 0.05 this time round. And what it shows, yes, it does have significant difference in terms of myopia progression. So after 2 years, the child has stable myopia. What will you manage? So first, the child is on low dose. Will you continue treatment, extend follow-up, taper atropine eye drops, or discharge the patient? So in this case, I managed by tapering the atropine eye drops. Rather than to stop completely, is because there can be risk of rebound, as we can see here. There is frequent risk of rebound if we suddenly stop the atropine eye drops. Similarly, there is risk for rebound for axial length if we stop suddenly. I'd just like to finish the last few slides. How do we taper atropine eye drops? So we taper atropine eye drops in this case by tapering the frequency of the eye drops, cutting down the eye drops instead of every night, 6, 5, 4, 3, 2, 1, every 3 monthly. That's how we taper the eye drops. So I'd like to thank everyone for the very kind attention. Thank you very much.
Do you have any questions for Dr. Fu? Okay, great. Thank you. Fantastic presentation, very action-packed. So we've had some great talks on myopia, so we're going to top them all by Mr. Myopia himself, Professor Yam, who needs no introduction. He's a professor of ophthalmology at the Chinese University of Hong Kong and has published many landmark studies on myopia, and we're really delighted to have him with us today. Jason.
Thank you. Thank you, Sarab, for the very kind introduction. And I would like to thanks again Professor Amela for the very kind invitation for us to be here. And I'm deeply honored to be here. So today I would like to share about on the topic of cost effectiveness. The cost effectiveness of myopia intervention. So just to share some of our work that has been done in CHK, we do in Hong Kong, in the Hong Kong Children Eye Study, the Hong Kong Children Eye Genetic Study, and the LAM1 and LAM2 study. That the Hong Kong Children Eye Study that we have been doing now is already 10 years. Over the last 10 years, we have kept recruiting children from Hong Kong. Every weekend, we recruit 100 children, and with detailed questionnaires, detailed eye examination, and some biosampling. And we build up a biobank. Now have the children that we recruited, about 45,000 children and 90,000 parents. It's also a public health campaign that we go to the shopping mall, we go to the schools to do the screening, and we have recruited, involved a lot of eye doctors in Hong Kong, optometrists, nurses, medical students, nursing students. We've managed to publish a few papers, and also we have published the LAM1 study and also the LAM2 study, and we are very thankful for the funding that we obtained over the last 10 years. So today my topic is not just on the intervention but on the cost effectiveness. The reason is myopia prevalence keep increasing. By 2050, we will have more than roughly 50% of the whole world become myopic. And the impact of myopia, including the impaired vision and also the poorer quality of life, affect the learning ability, activity limitation, and emotion. And so, when we talk about the cost, there is a global potential productivity loss of a huge amount. And in Singapore has reported the annual direct cost is $25 million in Singapore teenager in the cost. And individual lifetime cost is also a huge amount. So myopia progression has reported, mentioned by our dear colleagues just now. There's a various different intervention, including the spectacles, including the contact lens, red light therapy, pharmacological agents, lifestyle modification. So cost-effective analysis is a form of economic analysis that compares the relative costs and the outcome of different courses of actions. So it helps us to determine how best that we can spend the money for maximum quality and quantity of life. It also helps us to know the value that is in exchange of the resources. This is important kind of to help the policymaker on the economical benefits on the intervention to reduce the disease-related mortality and morbidity. So we have in this cost-effective analysis, we have two models. One is simple decision analysis tree model, and the other is state transition model, is Markov model. For myopia, it is kind of chronic state, so we use a Markov model. And so myopia, the preference increasing, there's a high economic cost, there's increased demand for the services. In the limited resources, we believe a cost-effective analysis is important, that to tell the policymaker in how we can spend well on this treatment. So before the cost-effective analysis, we do a systematic review to understand what is the current literature knowing about the CEA of myopia management. And interestingly, it didn't have many papers. It only have one paper on the myopia progression with atropine 0.01%, 2 studies evaluating refractive surgery, and 3 papers evaluating on the myopic CMV with the injection. So with this, this is a summary of the systematic review of the cost-effective analysis of myopia management. Atropine 0.01% is cost-effective. The ranibizumab was cost-effective in the United Kingdom, and the Corbicet was more cost-effective than ranibizumab in China. So this summary let us know that in fact the cost-effective analysis of myopia intervention was unknown, and there's not many data has been compared to which cost-effective analysis, to which intervention is important. So therefore, we conduct a study to look into the cost-effective analysis of various myopia interventions and then in children. So what we do is we compare 13 myopia interventions in terms of the spectacles, in terms of the contact lens, pharmacological lifestyle intervention, and the light therapy. And we use a Markov model for this, and we incorporate the level into health state into low myopia, moderate myopia, and high myopia. And we use a hypothetical cohort of 10 years old children. And then we look into it for a period of 5 years. And so we include the cost, effectiveness, and the transition probability. So the cost in this study was mainly based on the charges in hospital authority in Hong Kong. So it is the cost may vary when we apply to various regions and countries. So this analysis is based on the cost in Hong Kong. The outcome of effectiveness was obtained from published studies, and we calculate the rate of myopia progression and also from the published study. So here we can see it is the CEA plane showing the cost-effectiveness of intervention in terms of the refraction. And in fact, the result shows that the outdoor activity, here you can see the outdoor activity, and also 0.05% atropine, and the red light therapy was cost-effective. And comparing to the single vision lens, outdoor activity, and also the followed by the atropine 0.05%, and the red light therapy is cost-effective. And based on the axial length, again, the outdoor activity were more cost-effective, followed by 0.05% atropine and the OK lens. And in the probability sensitivity analysis, the cost-effectiveness over several, we also look into the willingness to pay threshold. And the outdoor activity was more likely to be cost-effective at a lower willingness to pay threshold, while atropine 0.05% atropine were more likely to be cost-effective as the willingness to pay threshold increased. You can see that when the willingness to pay threshold is low, outdoor activity is very cost-effective, but when it increases, the more cost-effective is 0.05% atropine. So the red light therapy and also the HAL lens were cost-effective when it compared to intervention, depending on the willingness to pay threshold. So to summarize, atropine 0.05% atropine and also outdoor activity are two most cost-effective interventions for controlling myopia progression in children. at a more expensive, a more higher willingness to pay, the red light therapy, HAL lens, OK lens, also can be cost effective. And the use of intervention can help us to understand in what way cost effectiveness help us to control myopia in an effective way. So I'd like to stop here. Thank you to all the funding agencies. Thank you to my department for all the work together. And once again, I would like to thank the organizer for allowing me to be here to share the work that we have been doing. Thank you very much.
Thank you very much, Jason. Fantastic talk as always. Any questions for Professor Yam? Okay, if not, we'll move on. Would like to invite to the stage Dr. Soumya Ravindra Murthy, who's a consultant in pediatric ophthalmology at the Sankara Eye Hospital, Bengaluru, to talk to you about recent advances in amblyopia.
Very good afternoon, everybody. And at the outset, I would like to thank the APSPOs for the kind invite. Shifting our gaze from myopia, we would be discussing a little about recent advances in amblyopia. The overview of my talk would be to understand a little about what is the recent things that we know about amblyopia, what are the screening technologies in amblyopia, our own screening innovation at Sankara, which is called Kanna photo screener using the artificial intelligence, the recent treatment modalities which are available, and our own experience regarding the same, and where do we stand now. The recent understanding, let's look at what we know so far with respect to amblyopia is that it has a critical sensitive period, and that's beyond the sensitive period, there is no plasticity which is left. So the recent understanding is that there is a residual plasticity beyond 8 years of age, and this is the game changer in terms of amblyopia management. So what is that implied to our clinical practice is basically that the uniocular amblyopes retain intact binocular processes, and that is generally suppressed, not irreversibly lost. That exactly goes on to say that monocularity in amblyopia is functional, not structural. What does that imply? That means that the adult amblyopes also can be treated. The recent screening technologies are based on 3 different things, not based on picking up the amblyopia risk factors, but picking up the amblyopia per se, which could be based on binocular retinal bifringence, OKN visual acuity, or on artificial intelligence. Now let's look at this retinal bifringence, which is basically based on the radial arrangement of the fibers at the fovea and also the bifringent property of the outer layer of Henle. What it implies to us, a circular spotlight of a particular frequency when it hits the fovea. If the fixation is CSM, that is steady and maintained, it gives you a backup frequency of 200 Hertz. When it is parafoveal, it gives the same frequency. That means it gives a indication as a pass, which means the child has no amblyopia, versus microstrabismus or amblyopia, which means it's to be referred. So that becomes a screening device. The next important device that we have on the block is using the vanishing optotype, which picks up the OKN. Unlike the grating recordings that we have in the OKN nystagmus visual acuity, this uses a vanishing optotype, similar to our Cardiff. They have pertained, this basically involves an inexpensive portable iPad with an eye camera incorporated in it, and also the facial feature recognition software takes care of the head movements of the child, so that is getting nullified, and the analysis software gives you an OKN nystagmus graph, which helps us understand if the OKN is present or absent, picking up the amblyopia. The next important thing is with respect to using the artificial intelligence, what we have developed our own algorithm. This was basically developed by 2 high school children, one of whom is amblyopic. So we use the same photographs which is taken across and run along the algorithm to pick up the amblyopia risk factors. We use the same to validate in nearly 654 children at our hospital, and picked up the amblyopia risk factors by this screener versus the complete ophthalmic examination. What we found, the results were interesting. We could get the images in all the children in nearly 97%. When we looked at the PHI coefficient, it strongly correlated for amblyopia and strabismus, picked up by the clinician versus by the photo screener were almost the same. We had a sensitivity and specificity which was close to 90%. So this could be used as an effective screening alternative, especially in a mass screening in school health camps. Now, the recent therapeutic approaches could be ranging from a perceptual learning to binocular therapy to newer interventions. Now, a word about perceptual learning. What it exactly implies is practice makes man perfect. The stimulus which is used here is the same for both the eyes, unlike in binocular therapy, which could act at various levels, though it is not very clear, by reduction of lateral inhibition or internal noise or improving the cognitive learning processes. The various evidences why perceptual learning should work across the studies. It has shown improvement in the contrast in the visual acuity, both in trained and non-trained visual tasks as well. A significant reduction in the contrast thresholds of the amblyopic eye has also been noted. What is the criticism against perceptual learning is basically all the studies have smaller participants. All of these are task-specific trained gains, and there is no the need for the home-based therapy, which is not available in perceptual learning, and a long-term follow-up, which is not available in these patients. Now coming on to binocular therapy, which basically uses a particular concept, that is, we use a high contrast, high luminance to the amblyopic eye versus a low contrast, low luminance to the non-amblyopic or a fellow eye. So it could be based on either anti-suppression therapy, a balanced binocular viewing, or an interactive binocular treatment system. So the various modalities, or the 6 modalities which are available are these. Now moving on to dichoptic therapy, which should work or which works based on reducing the active cortical inhibition. This is one of the representations of the same. So reduce the contrast of the fellow eye to a level that the amblyopic eye contrast is also seen. So this could be done using a dichoptic therapy or using an anaglyph glasses. We can also use an eye-bit therapy, which is based on the similar stimulus using a movie watching or a VR handset. A randomized control trial using an eye-bit system was comparable to that of a passive video watching as well. Now let's look at a quick look at all the randomized control trials using these systems compared with the patching. Most of them have compared with glasses versus these 3 studies, which are randomized control, compared to that of patching. And only these particular studies says that it is slightly better than patching, but the visual acuity improvement is on par with the patching. That means the binocular therapy, we are comparing with the gold standard, that is patching, and telling that it works, rather than saying it works better rather than that. What it also implies is that it's a promising option in both anisometropic amblyopia, not in the other forms of amblyopia. And what is also important is it has also shown improvement in stereopsis and sensory reversal in terms of relieving the suppression, unlike in case of patching. There is an interesting meta-analysis which published that there is no support for the efficacy of binocular treatment as a replacement or as an alternative for patching. It can be used as an adjunct rather than using as a primary therapy. And this particular this particular study throwed a little more light, saying that it showed improvement in par with the patching, but also showed improvement in contrast sensitivity and near stereo acuity, which was not seen with respect to patching. So it does show evidence in terms of improving stereo acuity, in terms of improving the contrast, but the age included in all the studies is very variable. The amount of or the type of amblyopia which is included is again variable. The prior history of patching, which may have an effect on the effectiveness of binocular therapy, is not mentioned. The games were thought to be more compliant compared to patching, unlike in the studies which proved the reverse. So our own work on the same, we use this binocular therapy in adult patients, that not in children, that is between 18 to 40 years of age, primarily included only the anisometropic amblyopes, not including those with strabismus or sensory deprivation. So this was just done before the onset of COVID, so we had a lot of problems with the COVID when continuing with the study, but we finished the study though. So the gaming we used was 30 minutes a day, 7 days a week, based on MFBF, that is monocular fixation in binocular field. So these were certain games that we use, basically using red and green glasses and using a various set of games where the adult is supposed to be using the glasses, playing 30 minutes a day, 7 days a week for 6 weeks continuously. And then we looked at the visual acuity. We had nearly 29 of them. Most of them were anisohyperopes and very less of anisomyope. We saw an improvement in both distance visual acuity and near visual acuity across all of them in mild, moderate and severe amblyopes. We also saw an improvement in both anisomyopes and anisohyperopes, though the visual acuity improvement was a little better in anisohyperopes. So we also noted that the contrast improved in all of them. Interesting thing was stereo acuity was improved in 7 out of 29 subjects of ours. We had a few limitations with respect to COVID, and we had more anisohyperopes, and there was unequal distribution between mild, moderate and severe amblyopes. But this proved to be a game changer with a lot of adult patients coming to us with no options, and we could start them on this particular thing. In pipeline would be for the treatment would be using asynchronous conditioning, where we use the refractive gratings, but timely space between the two eyes, which has shown improvement in the perceptual dominance being changed, and the other one, which is a home-based therapy, which could be used on the same principle. The experimental drugs and the environmental changes have been used especially in animals, not extending to humans. And our own innovation in pipeline, we've used another device or another app which we have developed, which could be connected on the Android phone, and we use a virtual reality handset which is indigenously developed, and this is something that the child has to play by moving the head. This incorporates three different things. One, these gratings are based on the visual acuity of the amblyopic eye. This is similar to Geber's patches. Two, we use a split in the visual field, and we use that the car is seen by the amblyopic eye and the road is seen by the fellow eye. So that combines perceptual learning with binocular therapy with MFBF therapy, and we have completed recruiting the patients. We are just analyzing the results. We show promising results. Again, we have tried this out only in anisometropic amblyopes, not in the others. So where do we stand now currently? There is no level 1 evidence telling that we use binocular therapy in all the patients with amblyopia and replace it with patching. Yes, and the overall safety and effectiveness and the sustained effectiveness of binocular therapy still remains to be understood. Is there an ideal and perfect O2 screener where we can pick up every amblyope before they develop amblyopia? Probably no. Binocular therapy as an adjunct or a primary modality, as an adjunct it proves much better. Optimal timing and treatment duration, we really don't know. What do we do about it? Applicability to all types of amblyopia, yes, works beautifully well in anisometropic amblyopes. Sensory deprivation probably doesn't work, and in strabismic amblyopes, yes, probably to an extent. Dose-response relationship, individual variability, we really don't know. Do we have enough engaging games to continue it for a long time? We really don't know. Sustenance of visual acuity gain achieved? Again, we don't know. But does that mean we stop using binocular vision therapy? No, it has shown promising results in both adults and children, and it is on par with the patching. It also improves stereo acuity and contrast sensitivity. To sum it up, so useful and effective in anisometropic amblyopes, it does improve near stereo acuity, at greater visual acuity gain, and shortens the duration of therapy, especially in combination with patching. I would end this talk by quoting a few lines that I appended myself. Explored are the numerous ways to get rid of laziness in the form of penalty, patch, or gaming. We are near, yet so far from saying paradise lost and paradise gained. Thank you very much.
Thank you. We will leave the question to the end and to have a panel discussion. Thank you very much for the excellent talk and for the very important update for the advances in the amblyopia. So I would like to invite my co-chair, Professor Saurabh Jain, Professor in the UCL Medical School and also consultant ophthalmic surgeon in Royal Free London NHS Trust, UK, to share with us on the Botox for childhood strabismus. Professor Jain, please.
Thank you very much, Jason, and thank you, Amila, and to all of you for this very kind invitation to be back in Sri Lanka. So we've had some amazing talks with lots of science. So this talk, like most of strabismus, is free of any science, just to let you know. So I'm going to show you some cases where I think Botox can be useful in childhood strabismus. So my name is Saurabh. I work in London at the Royal Free and UCLH hospitals, and I am in charge of Year 2 at the UCL Medical School. So if you're ever in London, please do drop me a line. I'd love to see you and show you around our centers. I'm going to talk to you about botulinum toxin. Now this drug has been around for a long time. Since the 1980s, we use it in strabismus, and what we know is that this drug is split by the proteolytic cleavage enzymes within our body into the active the active drug, and the drug tends to block the neurotransmitter junctions to limit the release of acetylcholine, and by doing so, it limits the contraction of muscles, and that's how we've been using it. You have many different preparations. The one that we use in London mostly is Botox, which is botulinum toxin type 8 produced by Allergan, but you can also get Dysport and Xeomin. And all of them have slightly different dilution. So that's the important thing. The pharmacokinetics is also important. And what happens is when you inject somebody with Botox, and I say to all my patients, nothing will happen today or tomorrow. It starts working in about a week. It tends to peak between 3 and 4 weeks, and the effect tends to gradually wear off over 3 or 4 months. And this graph is really important, and we'll come back to it in a second. So what I'm going to do is show you 5 cases where I think Botox can be used in childhood strabismus, and I'd love to hear your experiences as well. So this is the first case. This is an 8-month-old boy whose mom noticed his eyes deviating soon after birth. otherwise fine. You can see him sitting there happily with a large angle esotropia. So we know what this is, right? This is a essential infantile esotropia. This is something that we see often. It's a young child with large angle esotropia, no refractive error, and they tend to get this cross fixation. So they look to one side. They tend to not show any abduction because they're fixing with the other eye. Okay, so when you first see them, it may look like a sixth-nerve palsy. It's not. It is an essential infantile esotropia. So just patch one eye, and you can see the abduction tends to improve. So there are many, many ways to treat infantile esotropia. Now, that's a bad thing. But there are many ways to treat something, means there's no one good way. So you can either observe them, try and treat the refractive error, but they tend not to have very much, or you can operate. Okay, you can do a bimedial recession, or you can do recess-resect. Studies have shown they're almost the same in efficacy. Or you can try toxin. And so the two ways of doing the toxin. So I usually use the same needle I use for adults because you have that surgical proprioception. And you can use EMG monitoring, but you don't actually get much benefit if they're under general anesthetic. You need to use ketamine. Or you can use this Mendonca forceps, which I've just obtained. And this is a video from Dr. Salgado, because used much more in Latin America. And what you do is these forceps are really good at actually going and grasping the muscles. So you get much better accuracy of your injection. So what do you want to see? You want to see this convert to this after 3 weeks. You want to see a induced exotropia, because then what you're trying to do, you're trying to reset the visual symptoms. And over time, when everything settles down, another of my cases, you want to see nice straight eyes after injection of Botox. So does it work? And does it work as well as surgery? Well, this is one of the largest studies by Alejandra Campomanes, who is in UCLA. And they looked at almost 450 patients. And the largest group had toxin, the rest had surgery. And they used 5 units for less than 50, 7.5 for more than 50. And this really is all the findings in one key graph. If you have a deviation of less than 30 diopters, they are both similar. Okay? Although you may need more than one injection, so you have to balance the need to take the child to theater more than once against the need, against that they have no scarring. If you're more than 30, you're probably better off having surgery from the beginning. Okay? This is a fantastic meta-analysis in IOBS in 2017 that looked at all the big studies using toxin in infantile esotropia. And this is really difficult, right? Randomizing things are always difficult. To randomize strabismus in children is more difficult still. But they came up with some really interesting findings. So in all these groups, the mean deviation before treatment was about 40. After treatment was about 6. So it really works. Okay? But as I said, you do need sometimes more than one injection. Okay, the higher the dose injected, the lower the success rate. Now that seems a bit counterintuitive, but actually it makes sense, because the higher the dose injected means the bigger the deviation, which probably is why they didn't have much success. And they found that open sky worked. If you use EMG guided, it works as good as open sky. And to me, open sky just means opening the conjunctiva. And to me, that makes no sense. If you're doing a non-interventional procedure, you should really leave the conjunctiva alone. And I tend to just use EMG guidance in these children. If you can use ketamine, you get a good signal. But if you can't, I still use the same apparatus. Any complications? Well, consecutive exotropia, which you sort of want really, but what you do not want is ptosis, because if you give this child a ptosis, the young children with a lot of neuroplasticity, you do not want to give them amblyopia. And what I found is if you leave the needle in the track for at least 60 seconds, or if you can raise the head end of the bed, that reduces the incidence of ptosis drastically. Okay? There's a bit of vertical deviation. There was one paper in 2016, and you can see this child had induced ptosis, but they also got an atonic pupil. So I'll go to my next case. This is also a young child with large angle esotropia. But the difference here is that they have periventricular leukomalacia and developmental delay. Now, this is not a group of children that you really want to operate on early, because there's a high degree of variability, and we know that they might go exotropic over time. Their parents are really keen on doing something, so he had one injection of toxin. This was after him in 3 weeks, and now he's 5 years later, and he has not had any recurrence of his strabismus. So we published this a while ago, showing that toxin works really well in children with cerebral palsy and PVL. This is the third case. This is a 14-year-old girl who came with double vision, progressing over the last few weeks. She had a history of dizziness maybe 10 months ago, but otherwise absolutely fine. On examination, she has a sudden onset large angle esotropia, but otherwise fine. Full motility, so we know it's not a sixth nerve palsy. Very low hypermetropia, and when we look at a Hess chart, it's absolutely normal. So this girl essentially has an acquired non-accommodative comitant esotropia. The three different kinds you see, and she really has the Franchetti types. The Burien Franchetti type is an acute onset esotropia with no signs of paralysis, good potential for BSV and low hypermetropia. So she did really well with injection of toxin to both medial recti. This is another condition in which it is quite useful, and you can do the older case just with some sedation. There's another case we published in 2014. This is a child whose mom was very specific. She said one day he has a squint, the other day he doesn't. And she's right. Mothers are always right. So if a mother says this child has something, listen to them because they know what they're talking about. And you can see here, they have straight, esotropic. And actually she'd even made a calendar, and she'd marked good day, bad day, good day, bad day, good day, bad day. So this is a cyclical esotropia. So on a good day, absolutely everything is fine. On a bad day, they have a large angle esotropia. So we treated them. So this is a therapeutic dilemma because you don't really want to operate. If you do operate, you have to operate on the full angle, and people do get a bit anxious because you're treating a normal child. They come on a good day on the day of surgery. So we gave this child some toxin, and they responded really well. This was the first report of using toxin in cyclical esotropia, which we published in JPOS. And these children are another group in which you might want to consider using toxin. This is another child. This is the one we're talking about. Is a girl from Hong Kong who flies to London to get her toxin injections every 6 months. I've tried to dissuade them. And here's another child, and she has continuous cycles of cyclical esotropia. So I'm going to finish with this case because this case gave me a lot of sleepless nights. It started off quite easy, quite nicely. 8-year-old girl with a large angle exotropia that she could control from time to time. So she has some stereo when she controlled it. So that seemed straightforward. So we offered her some surgery, resect, and I was just expecting she'd do well. She didn't. So she had a large angle consecutive esotropia, a lot of unhappiness. Her stereopsis disappeared. So we said, okay, we will wait. Maybe this will get better with time. It didn't. 4 weeks later, she's still very esotropic. Now, this is a problem, right? Because there's a loss of stereopsis. The family is very unhappy. There's a big overcorrection. So in this case, we use some toxin to both eyes. And it initially worked really well. Okay, 1 week afterwards, worked really well. Everybody was happy, me, the mother. But remember this graph I showed you? We know the peak effect will occur in about 4 weeks. And this is exactly what happened. This is 6 weeks later. This is 3 weeks later. Now she's got a huge overcorrection. Family is very unhappy. The squint has returned. What have you done? But again, remember the graph. It will go down. So lots and lots of reassurance. And 6 months after the injection, both mother and child are very happy. Full restoration of binocularity. And they are well controlled and been discharged. So just to finish, these are the indications of use of toxin pediatric strabismus in small angle infantile esotropia, less than 30 diopter, those with developmental delay or plasticity, but the angle is variable. Consecutive exotropia or esotropia as a rescue mechanism, acute acquired esotropia. Now the last two I've not really talked about because it's not very common in children, but in adults, you can also use them as adjunct to surgery of sixth nerve palsy and in exotropia. Thank you very much for your attention.
Thank you very much, Professor Jane. We will leave the discussion at the end. So we'll invite our next speaker. Yes, Professor Sita Agrawal, from a professor in ophthalmology in charge of the Strabismus and Pediatric Vision Clinic of Department and KGMU, India, to share with us on pediatric cataract for beginners.
Good afternoon. I am happy and proud to be part of this APS-POS session. I would be touching on some important points for surgeons who are considering starting pediatric cataract surgery. Paying attention to them would make their initial experiences with pediatric cataract a pleasant one. Preoperatively, the surgeons who are considering starting pediatric cataract should be well versed with adult cataract surgery and should have performed a certain number of pediatric trauma cases. They should perform their initial 50 cases under supervision. regarding patient selection, it makes sense to select older children, avoid comorbid conditions like microphthalmos, coloboma, insist on a recent B scan to rule out posterior segment involvement. It makes sense to implant IOL in children older than 6 months and those who have normal sized eyes. The SRK-T or Holiday 2 work well in younger children. And the choice of implant is hydrophobic acrylic. There should be no shortcuts in preoperative counseling. The parents need to be talked in detail about the need of glasses, the long-term follow-up, possibility of amblyopia, resurgery, and all the complications. Take a detailed, informed consent. It takes care of a number of medico-legal issues later. Now coming to the interesting part, the surgery. Incisions in children tend to gape. So they should be biplanar or triplanar. They should be slightly longer than those you make in adult. Pay attention to these diagrams. They show that the inner opening and the outer opening are on different planes. The side port incision should be made with an MVR blade and it should be a clean entry. Keep in mind not to extend the incision while withdrawing the blade. The main incision, the entry should be made by making the blade vertical so that the inner lip is valvular. Also, you may consider making the main incision after completing the capsular excess for better chamber stability. The most difficult part of pediatric cataract surgery is management of the capsules. First, I'll talk about the anterior capsular excess. The chamber should be deep and you should make small, gentle pulls, and you'll need to pull, the pulls should be minimal and repeated. Like if you are making, like Dr. Khokar had said in the morning, if you are making 5 pulls in adult, here they should be 7 to 8. Staining the capsule, if visibility is an issue, it should be done with trypan blue. Note here again that the pulls would be repeated and gentle. You can either use a cystotome or an Uttrata forceps. You need to regrasp, deepen the chamber, and the capsular excess has to be completed from outside within. Aim for a rhexis which is smaller than what you are actually aiming, and you would, as the rhexis would eventually gape on completion. If you are aiming for a 4 mm rhexis, you will end up with a 5 mm one. Now sometimes the capsule would be unyielding to either the Uttrata forceps or the cystotome or even the vitrector. So you need to enlarge the incision and do the capsulotomy with a Vannas scissor. Initially you make this opening and you may need to even to smoothen out the edges later. Once the capsular excess is done, hydrodissection and cortical aspiration and management of the nucleus is relatively easy. The nucleus just flows out with adequate hydrodissection. And the cortical management can be done like you do in adults. Now, the posterior capsule management is again tricky. Here I would be showing an opaque posterior capsule. The chamber should be filled with a viscocohesive OVD, and it should not be overfilled. It should be just adequate, otherwise the posterior capsule will tend to bow backwards and go away from your plane of focus and make the management even difficult. Here again, you would be making small, gentle pulls, regrasp the capsule as the capsule advances, and aim for a posterior capsular opening which is smaller than the anterior capsule one. A useful technique to be followed by beginners is that you perform the posterior capsulotomy after implanting the intraocular lens. I prefer to take a suture after the IOL implantation when the chamber is still filled with viscoelastic. Then you manipulate the, I've just taken the suture bite, I've not tied it. Then you manipulate the vitrector behind the IOL, and the irrigation can be managed through the same incision, or you can have a separate port for it. The vitrector access is initiated with the mouth of the vitrector facing backward. It is extended by rotating the vitrector forward, and then you proceed with a liberal anterior vitrectomy. The surgery subsequently needs completion just by tying the suture. Now, a few tips about IOL implantation if you are doing it after performing the posterior capsular access. Here, the leading haptic should go in between the capsular rims, and the trailing haptic should open in the anterior chamber or in the sulcus. This is achieved by slightly withdrawing the injector as the leading haptic unfolds and depressing it. Subsequently, the trailing haptic needs to be dialed in place with a Sinskey hook. Now, these photographs show the ideal placement of the IOL. The first photograph on your left is showing the IOL placement between the capsular rims. The second one shows the capture of the IOL optic in the posterior capsule while the haptics are in the capsular bag. This technique should be gradually learned by all pediatric cataract surgeons for good outcomes. Incisions in children need to be closed. Suture tying and suture tightening with an air bubble in the anterior chamber and observing the shape of the air bubble gives you an idea about the tautness of the suture. Doing a small peritomy initially to bury the suture makes sense. Post-operatively, the eyes should be bandaged. I prefer to keep the children admitted for at least 2 days post-operatively. The pediatric cataract surgeons should be suspicious for inflammation and infection, as the examination of the pediatric eye is difficult and the children are often uncooperative in the post-operative period. You should have a high index for suspicion and need to learn how to differentiate between these two conditions and start timely management. The examination should be performed without touching the eyes, and be ready for a long journey ahead with management of the changing refractive errors, amblyopia, and the visual axis opacification. All the best. Thank you.
Thank you so much. Thank you so much, Siddharth, for the excellent presentation, sharing with us on the cataract surgery. Yes, please.
Yeah.
I see you did your posterior capsulectomy before you put the lens in. I've got concerns about the placement of the lens. You had a successful operation. Why not do the posterior capsulectomy after the lens is in? All you have to do is tilt the lens up a little bit. The lens is already in place.
Yeah, I described both the options there. So for beginners, it is better to do the posterior capsular management after implanting the lens. That way, it's better because the IOL remains in the bag. However, the margin of the posterior capsular opening doesn't remain smooth with the vitrector. It becomes a ragged margin which is prone to extension. So the ideal management would be performing the posterior capsular access and implanting the IOL within the donut which is created. However, it's a technically challenging step to be performed. Requires a lot of practice because sometimes the IOL opens vertically and the leading haptic may go behind the posterior capsular opening. That makes it challenging.
Thank you. And now we have about 10 minutes for panel discussion. And we also have Professor Frank Martin, who will give us a closing remark after that. So our symposium, in fact, composed of several major topics involving myopia, amblyopia, strabismus, cataract, all this. So may I start with asking Dr. Sowaya for the amblyopia. So first I want to ask the audience, are there anyone using binocular therapy in your practice now for amblyopia? Maybe when I want to ask Dr. Saraya for what is your choice for treatment therapy now? Say when a child comes to you for amblyopia, are you still doing patching, or when you will seek alternative management?
Okay. So in the clinic, when I see a child with amblyopia, I usually start off with patching. Patching is my first line of therapy. I don't switch on to binocular therapy as my first modality of choice even today, though in our hands it has worked beautifully well. I use binocular therapy in certain set of conditions. 2 consecutive visits, no improvement in the vision at all with compliant patching, or the child is absolutely resistant to patching, and the parents are not able to get time for patching, but they are okay with trying the vision therapy because this software is available as a home therapy as well. So this could be given as a software where they download it in the laptop and use it at home, or when there is a mixture of 2 or more causes for amblyopia, like the patient has an isometropia but also has a strabismic component. That is when I use a binocular therapy as the first modality rather than just patching alone, but as a combination always.
Thank you. Thank you very much. And another question is asking also the audience, any one of you is using Botox for strabismus? Are you using in children, adult, or as Professor Jane has shared, is also using in children? So can I ask Professor Jane, for children using Botox, in my scenario, it's difficult to convince the parents that usually they need to put into sleep for what's your experience and how to manage that?
Yeah, thank you, Jason. I think that's a really fair point, because you have to balance the two issues, right? You're putting a child to sleep for a second time, whereas, what's the benefit you will get from toxins? So there's some very selected cases in which it is useful to do that. And, as in all the cases we've heard today, evidence-based medicine is your guide. So you say to them, well, studies have shown that we can do an operation for your esotropia, or there is a possibility that we can use just the Botox, but then there's you may need more than one GA. So then, you sort of involve the parents in the decision-making process. And, in cases if you can avoid surgery and avoid scarring, they just have to balance that against the risk of a general anesthetic.
Right. Yes, Siddharth, you want to give a comment? And also some colleague want to give a comment. Please. Yes.
I tell the parents that there's a 30% chance that your child may not require surgery after the first injection.
How many percent you say?
30%.
30% chance.
30%.
Okay.
For infantile esotropia. And
Okay.
more so where the general anesthesia fitness is doubtful, the child is low weight, then in the waiting period, Botox is the good option. More so when the measurements are not very accurate in small children, there Botox is very useful, because if the child is able to keep the eyes straight for just about 3 to 4 months because of the effect of Botox, the fusion develops. And then many of these children would eventually not require surgery.
Okay.
And if the parents are willing enough, you can repeat the injection after another 3 months, and then that percentage would go from 30% to maybe 50% of that, the children who don't require the definitive surgery. Okay. So that's a good percent. Like many of the parents, they get convinced for the injection. You tell them it's a much less invasive, you only need a small general anesthesia. So it's not difficult to convince.
Thank you. Another colleague wants to give comment.
Yes.
Maybe you can introduce yourself first.
Thank you so much. Basically, I have a question from Dr. Jain. So I started using esotropia and squint very recently after hearing you in one of the conferences in India, actually. So I have a question, that is, till what age do you recommend using Botox in children?
Thank you. Can you introduce, where do you work?
I am Associate Professor in Medical College, Kanpur, UP.
Very pleased to meet you. So, I think one of the things that's useful when offering toxin is the amount of the deviation. So I use that as a guide. So if it's a really large angle strabismus, you can still offer toxin, but then your end result changes. You can say, well, if I give you toxin, it might be that you settled from a 80 or 70 diopter esotropia to a 30 diopter esotropia. So you'll go from 3 muscles to 2 muscles. So that's one advantage. As children get older, because you can get the measurements much more accurately, and if they're more than 30 diopters, then I tend to offer them surgery. I don't offer toxin. But younger age, less than 30 diopter, variability of measurements, developmental delay, in all of these children, toxin is a good option in esotropia.
Okay, and one time I was doing surgery for a very large angle esotropia, and there was some residual. Yeah. So in that patient, I tried Botox. Although the patient was older, not a young child, I was operating, and I think it was some 12 to 14-year-old girl, and there was a residual esotropia. So I thought before going to surgery again, I tried Botox, and I had a wonderful result. Both eyes were straight. Now I have to see, how the patient comes after 4 to 6 months and what the result would be.
No, I think that's a good point. So residual or consecutive strabismus, toxin is a really good rescue therapy. The only thing from the rule, deviation from the rule, is if you have a big consecutive esotropia following surgery and there's limitation of abduction, just think of a slipped muscle. But otherwise, it's a really good option.
And can we go in the other eye as well? Sometimes for the residual, sometimes can we go to the other eye and try Botox in the other eye? Would it serve the purpose?
Absolutely. If there's no limitation of motility, it doesn't matter which eye you put it in.
Okay, thank you so much.
Thank you. Oh, there's two more. Yes, one by one, maybe. Yes, maybe.
For Dr. Jain.
Can you introduce yourself first?
I'm Hasanka. I work as a pediatric ophthalmologist in Galle, southern province, Sri Lanka. So if you have a child who's presenting at the age of between six months and 1 year, who's having a very large angle esotropia, maybe more than 45, would you consider giving the Botox first and then reassess and then go for surgery?
Yeah. Well, I think so it depends what you're chasing, right? In an esotropia, are you chasing stereopsis or you just want good alignment? I think I try not to operate in infantile esotropia really early because, as I said, the measurements are variable. So if the parents are keen and there's a large angle esotropia, I think it's absolutely sensible, and they want to do something, you can absolutely do some toxin. When they're older and you can get reliable measurements, and if they are large angle, then on the whole, I prefer surgery. But I have many colleagues who will still offer toxin first, so I think there's no hard and fast rule.
What's your view on augmenting with Botox if you're doing for a large angle recession, maybe after 1 year or so?
So we actually looked at that. We looked at our sensory exotropes. So these are people who have big 50, 60 diopters, XTs, and they only want the one eye done because that's the eye with the poor vision. So we looked at using toxin as a chemical traction suture almost. So we did toxin 2 weeks before the surgery. We found actually long-term there was no difference in the two groups. They still settled to the same angle. So we didn't find a big benefit. But I think, again, in that group, you need all the help you can get. So I don't see any drawback to using it.
Thank you.
Thank you. In the interest of time, one last question, and then we'll invite Professor Martin to give us a closing remark. Yes. Can you introduce yourself first?
I am Dr. Usha Johri from Bombay. I have burnt my fingers several times, injecting Botox on a child with cerebral palsy, because I always felt that there is a spasticity of the muscle, and so injecting Botox would really help. But once the child is given general anesthesia, it's very difficult to assess what is the relation between the spasticity of the muscle and the relaxation of the muscle. So I just wanted your opinion about this.
So I think one thing that really, I think you're absolutely right. Because these kids get toxin all over their body, actually. They get spasticity and they get flexure contractures, etc. So I use the FDT as a guide. So it depends how much you can move the eye. Now, it's been shown, even in infantile esotropes, the muscle is very tonic. So even in them, there is a bit of limitation of abduction. So if you do an FDT and there's limitation of abduction, I think this supports your decision to put in toxin.
Would you prefer to inject Botox in a patient who has already been operated and there is a, strabismus, would you inject Botox in those cases, or do you feel that there will be a lot of fibrosis and Botox may not work?
So it again depends. It depends upon the amount of deviation, and if they've had say a bimedial recession and they still have a large angle esotropia, then I think it's a viable option. In these kids, usually I tend to do bilateral LR resection, and I do a bit more than I've got a little table I use. But yes, absolutely, if the parents are not keen on more surgery, and I have many families who do not want any more scarring, it's an absolutely worthwhile option to try.
Thank you.
Thank you. I think we have an excellent discussion. And because of time, otherwise we can have many discussions to follow. So I would like to invite Professor Frank Martin, who is the president of our Asia Pacific Pediatric Ophthalmology and Strabismus Society, to give us a closing remark. Professor Frank Martin, can you hear us?
Yes, thank you very much, Jason, and thanks, Jason and Sabran, for chairing such an interesting session, and for the speakers for sharing their knowledge with us. I learned a lot, and I'm sure you all learned something from this. APSPOS is the Paediatric Ophthalmology and Strabismus Society of the Asia Pacific region. It's a relatively new society, it's growing. Next year in Brisbane, the 29th of June to the 1st of July, we're having our third conference. It's back-to-back with the International Orthoptic Congress, and I'd like to invite everyone to attend and participate. It will be a good meeting, and when you get paediatric ophthalmologists together, we always have fun. So thank you very much, and I'd like to thank Emila de Albus for inviting APSPOS to have the opportunity to have a symposium at your annual Congress. Thank you.
Thank you, Professor Martin. Please stay here. We would like to take a group picture together with you. Please stay. So I think it is, we will end this session, and we invite our speaker to come on the stage, including our president, Emila de Albus, professor, come on the stage to have a group picture.